This voiceover will focus on pancreatitis, which will include acute and chronic pancreatitis. We will do a quick review of the structure and function of the pancreas, which will make it a little bit more easier when we go into the major topics. The pancreas is a long, slender gland that sits behind the stomach and in front of the first and second lumbar vertebrae. The anterior is covered by the peritoneum. The pancreas has both exocrine and endocrine functions. The exocrine function contributes to digestion by the production and release of enzymes. The endocrine function is to secrete insulin and amylin, which is a hormone that works by slowing gastric emptying or movement of food from the stomach into the intestine. Pancreatic enzymes work to digest food. Stomach acid or hydrochloric acid is secreted and breaks food down and causes the release of pancreatic enzymes that will assist in the digestion of food. Amylase is secreted to digest starch to disaccharides, lipase for fat digestion, trypsinogen and chymotrypsin for protein digestion. The process of aging also has an effect on the GI system. Loss of teeth can create difficulties at the start of the digestive process. Taste buds change, in particular with salt and sweet, and the mouth becomes dry. Specific to the pancreas, pancreatic ducts become distended, lipase production decreases, and pancreatic reserve is impaired, all contributing to impaired fat absorption and a decrease in glucose tolerance. Pancreatitis is a disease characterized by inflammation of the pancreas and is classified as acute or chronic and can be life-threatening. The degree of inflammation can vary from mild edema or interstitial pancreatitis to severe pancreatitis or hemorrhagic necrosis or necrotizing pancreatitis. Patients with mild pancreatitis usually recovers fully with therapeutic treatments. There's no organ damage and there's usually a very low mortality rate. Severe acute pancreatitis is most common in middle-aged men more than women. These patients may develop a damage to their major organs, pancreatic necrosis, organ failure, or septic complications. Acute pancreatitis is also associated with elevated triglycerides and obstruction of pancreatic ducts, resulting in pancreatic ischemia. Chronic pancreatitis is a continuous, prolonged inflammatory and fibrosing process of the pancreas and surrounding tissues. Here, the pancreas is progressively destroyed and replaced by fibrotic tissue. Strictures and calcification may also occur in the pancreas, causing pancreatitis. Alcohol abuse and obstruction caused by gallstones are the two most common causes of this condition. Other causes include tumors, pseudocysts, or trauma. Systemic diseases, autoimmune, pancreatitis, and cystic fibrosis are also conditions that may contribute to chronic pancreatitis. In non-obstructive pancreatitis, inflammation and sclerosis around the head of the pancreas and around the pancreatic duct is the most common form of chronic pancreatitis. Autodigestion. In autodigestion, pancreatic enzymes digest the pancreas and the surrounding tissues. This is a reversible process that causes inflammation of the pancreas and acute pancreatitis. A sudden onset of epigastric pain is the primary symptom of both acute and chronic pancreatitis. The pain will present differently between the two. In acute pancreatitis, abdominal pain is present in the upper quadrant and commonly radiates to the back or shoulder blades. The pain with acute pancreatitis is sudden, severe, and deep. It is piercing and continuous. It may rapidly worsen after eating a high fat meal and when lying flat or bending forward. The patient may experience nausea and vomiting and a loss of appetite. They may also have bloating from gas, hiccups, indigestion, fever, tachycardia, and hypertension. For the individual suffering with chronic pancreatitis, the discomfort will be a heavy, gnawing, burning, cramp like pain in the left upper quadrant. It is described as constant and it affects ADL. This pain can spread to the back and feels worse after eating or drinking. The pain is associated with distension of the pancreas, peritoneal irritation, and biliary tract obstruction. It is also made worse by drinking alcohol. This pain associated with chronic pancreatitis may diminish, which is an indication that the pancreas is becoming fibrotic or is developing fibrosis. The pain of chronic pancreatitis, it is not relieved with food or antacid. The onset of acute pancreatitis will occur when the client is in a recumbent position or laying down. There is no relief of discomfort with vomiting, and pain will typically be accompanied by flushing, cyanosis, and dyspnea. The client will experience abdominal tenderness with muscle guarding, bowel sounds may be decreased or absent, and there should be concerns regarding paralytic ileus as this may occur with acute pancreatitis. The client may have marked abdominal distensions, and the lungs are frequently involved as crackles may be present on assessment. As with acute pancreatitis, the client with chronic pancreatitis will experience abdominal pain. The attacks will become more frequent until they are almost constant, or they may be diminished because of the development of fibrosis. In addition to the symptoms typically associated with acute pancreatitis, the individual may experience symptoms associated with pancreatic insufficiency, for example, malabsorption resulting in weight loss. Constipation and mild jaundice may be evident in the client with chronic pancreatitis. In cases of acute pancreatitis, intravascular damage may cause areas of cyanosis or greenish to yellow-brown discoloration of the abdominal wall. Gray Turner spots is a bluish discoloration to the flank, and Collins sign is a bluish discoloration of the periumbilical region. These signs are a result of seepage of blood-stained exudate from the pancreas and may be evident in severe cases. In severe cases of acute pancreatitis, shock may occur related to hemorrhage into the pancreas, toxemia from the activated pancreatic enzymes, or hypovolemia resulting from a fluid shift into the retroperitoneal space, and this shift may be a massive fluid shift. For clients with chronic pancreatitis, their urine may be dark, and they may experience steatorrhea and diabetes mellitus. Steatorrhea is severe, voluminous, and foul-smelling fatty stools, and it will be seen in clients with chronic pancreatitis. Diagnostic studies associated with acute pancreatitis are elevated levels of serum amylase, lipase, urinary amylase, blood glucose, triglyceride, and decreased serum calcium levels. For cases of acute pancreatitis, the primary systemic complication includes pleural effusion, atelectasis, pneumonia, adult respiratory distress syndrome, as well as cardiovascular complications such as hypotension and tetany related to hypocalcemia. Complications associated with chronic pancreatitis includes the formation of pseudocysts. An acute pancreatic pseudocyst is made of pancreatic fluids with a wall of fibrous tissue or granulation. Bile duct or duodenal obstruction may occur in these cases. The client may experience pancreatic ascites or pleural effusion. Splenic vein thrombosis, pseudoaneurysm, and pancreatic cancers are also complications associated with chronic pancreatitis. A pseudoaneurysm is also known as a false aneurysm and is a collection of blood that forms between the two outer layers of an artery. Diagnostic evaluation for cases of acute pancreatitis are also directed at determining a cause for the acute episode. The client's amylase and lipase levels may be elevated for the first 24 to 72 hours. Abdominal ultrasound and imaging may be used to diagnose acute pancreatitis. Confirming a diagnosis of chronic pancreatitis can be difficult. Diagnosis is based on the individual's signs and symptoms, blood work, and medical imaging. In individuals with chronic pancreatitis, serum amylase can be slightly elevated or within normal limit, depending on the degree of pancreatic fibrosis. Serum lipase may also have similar results. Bilirubin and alkaline phosphatase levels may be increased. Leukocytosis or a mild elevation in leukocytes may also be noted. The individual's sedimentation rate will also be increased. For cases of acute pancreatitis, X-ray and contrast-enhanced CT are usually used for identifying pancreatic problems. CT is the best imaging to determine pancreatitis. For cases of chronic pancreatitis, the client will undergo more extensive medical imaging studies, such as an endoscopy, to visualize the pancreas and a common bile duct. CT, MRI, abdominal ultrasound, and endoscopic ultrasound may also be used to visualize the pancreas and confirm diagnosis. Stool specimens are obtained and tested for fat content. Lipase assists with the digestion of fat, and an increased fat content of the feces would be an indication of poor fat digestion. For clients with acute pancreatitis, treatment is mainly focused on supportive care, which includes aggressive hydration, pain management, and minimizing stimulation of the pancreas. The treatment of and control of pain are essential. IV morphine may be prescribed. Analgesics may be combined with antispasmodic agents. Atropine and other anticholinergic medications should be avoided in clients where a paralytic ileus is present. The decrease in GI mobility will contribute to the problem. The patient should be administered supplemental oxygen to maintain their oxygen levels above 95%. For clients with severe pancreatitis, glucose levels must be closely monitored for hyperglycemia. If shock is present, blood volume replacements are initiated. Plasma or plasma volume expanders such as albumin may be administered. Fluid and electrolyte imbalances are corrected with the infusion of lactated ringers or other electrolyte solution. It is essential to decrease stimulation of the pancreas and reduce or suppress pancreatic enzymes, thereby allowing the pancreas to rest. To achieve this decreased stimulation, the client may be NPO and have an NG suctioning to reduce vomiting and gastric distension. This also prevents gastric content from entering the duodenum. Medications may also be prescribed to suppress gastric acid secretion. As the pancreatitis resolves, the client will resume normal oral intake. For clients with acute necrotizing pancreatitis, infection is a leading cause of morbidity and mortality. It is absolutely essential that infections be prevented. Since many of the organisms come from the intestine, enteral feeding will reduce the risk of necrotizing pancreatitis. Antibiotic therapy can be started early if necrosis and infection occurs. The treatment for The client with chronic pancreatitis and the one who experiences an acute attack is the same, and this includes diet, pancreatic enzyme replacement, and control of diabetes. These are methods that actually work to control pancreatic insufficiency. Meals should be small, bland, low fat, and frequent. It is important to recognize that smoking is associated with acceleration of the progression of chronic pancreatitis. The client also needs to be instructed to avoid alcohol and caffeinated beverages. Pancreatic enzyme products containing amylase, lipase, and trypsin are used to replace deficient enzymes. Bile salts may sometimes be administered to facilitate absorption of fat soluble vitamins A, D, E, and K and prevent further fat loss. Should diabetes develop, it is controlled with insulin or oral hypoglycemic agents. Acid neutralizing medications and acid inhibiting drugs may be prescribed to decrease hydrochloric acid. Subjective and objective data should be obtained from the client with acute pancreatitis. This is also essential for the client with chronic pancreatitis during the acute phase. Subjective data should focus on the individual's important health information and functional health problems. Some of the areas are related to the individual's past health history. Have they experienced any biliary tract disease, alcohol use, abdominal trauma? What medications are they currently prescribed, specifically NSAIDs and thiazides? What is their past surgical history, specific to the pancreas, stomach, duodenum, or biliary tract? With regard to the individual's functional health, have they experienced any nausea, vomiting, or anorexia? Do they have any dyspnea with activity or exercise? Are they or have they experienced any severe mid epigastric or left upper quadrant pain that may have radiated to the neck? Was the discomfort aggravated by food and alcohol intake and unrelieved by vomiting? So, objectively, you are observing for any restlessness, anxiety, or low grade fever. Is the client flushed with any diaphoresis? Is discoloration of the abdomen and flanks noted? Are you observing any cyanosis, jaundice, decreased skin turgor, or dry mucous membranes? Is the client tachycardic? Do you note any basilar crackles? Is the client hypotensive? Is there any abdominal distension, tenderness, or guarding? Are bowel sounds diminished? Review of labs may demonstrate an increased serum amylase and lipase, leukocytosis, hyperglycemia, and hypocalcemia. Abdominal ultrasound and CT scans of the pancreas would also be ordered. The main goals on nursing management for acute and chronic pancreatitis during the acute phase are the client's relief of pain, maintaining a normal fluid and electrolyte balance, assisting to ensure minimal to no complications, and the prevention of any further attacks. Pain and restlessness can increase the patient's metabolic rate and subsequent stimulation of pancreatic enzymes. Morphine may be used for pain relief in clients with acute pancreatitis. Assessment of the client for predisposing conditions and the encouragement of early treatment of these factors to prevent acute pancreatitis is essential. Encourage early diagnosis and treatment of biliary tract diseases such as gallstone. The client needs encouragement to eliminate alcohol intake, and this is increasingly important, especially for patients who are experiencing a second or third attack. During the acute phase, the monitoring of vital signs is essential. The client's hemodynamic stability may be compromised related to hypotension, fever, and tachypnea. The client should be monitored for response to IV fluids. The monitoring of fluid and electrolyte balance is essential. If the client is experiencing frequent vomiting and gastric suctioning, a decrease in chloride, sodium, and potassium levels may be noted. Assessment of respiratory function is paramount as respiratory failure may develop in the client with severe pancreatitis. Lung sounds and oxygen saturation levels should be monitored. Hypocalcemia can also be a complication of acute pancreatitis, and therefore the nurse should be observing for symptoms of tetany. For example, jerking, irritability, and muscular twitching. Numbness or tingling around the lips and in the fingers can be an early indicator of hypocalcemia. Calcium gluconate may be given as an order to treat symptomatic hypocalcemia. Nursing management of chronic pancreatitis focuses on chronic care and health promotion. The patient should be instructed to take measures that will prevent further attacks. Consistency in treatment measures is essential along with compliance with taking prescribed pancreatic enzymes. The client's stool should be observed for steatorrhea in determining effectiveness of enzymes. If diabetes has developed, the client should be instructed on how to test blood glucose levels and drug therapy. The client must avoid alcohol, and assistance may be needed in dealing with this problem. Referrals to other agencies may be necessary, especially if the client is dependent on alcohol. Pancreatic cancer is the fourth leading cause of death from cancer in the United States. Around 35,000 individuals are diagnosed annually, and approximately 23% of these individuals will survive to 1 year. The risk increases with age. The exact cause is unknown, but there is some association with cigarette smoking, and these individuals are twice as likely to get pancreatic cancer as non smokers. A high fat diet, meat consumption, fried food, refined sugars, and nitrates. Patients with diabetes, chronic pancreatitis, or a family history of pancreatic cancer are also at a high risk of being diagnosed with the disease. The most common form of pancreatic cancer is ductal adenocarcinoma. It can spread quickly to other GI organs such as the liver, the stomach, the duodenum, or the intestines. Most pancreatic cancers are adenocarcinomas originating from the epithelium of the ductal system. Over half of the tumors occur in the head of the pancreas. Signs and symptoms of pancreatic cancer are frequently similar to those for individuals with chronic pancreatitis. Unfortunately, the cancer may metastasize by the time a diagnosis is made. The prognosis for the client with pancreatic cancer is oftentimes very poor. Dull, aching abdominal pain that is frequently located in the upper left hypochondrium and often radiates to the back is a primary symptom of pancreatic cancer. The client will often experience anorexia with associated weight loss, and this is due to poor digestion and absorption related to the lack of digestive enzymes from the pancreas. Jaundice will be present and pruritus may be experienced if the client has obstructive jaundice. A diagnosis is usually made using abdominal ultrasound, CT scan, ERCP, and MRI. These are the most common diagnostic imaging that is used for diagnosing pancreatic cancer. A definitive diagnosis for pancreatic cancer is usually achieved with the use of histology, and this would include ultrasound guided fine needle biopsy or excisional biopsy through a laparotomy. Surgical intervention will provide the most effective treatment for cancer of the pancreas. The typical surgical procedure is a radical Whipple procedure. This includes resecting the proximal pancreas, adjoining duodenum, distal portion of the stomach, and distal segment of the common bile duct. A vagotomy may also be done, and this involves resection of the vagus nerve to reduce acid secretion in the stomach and reduce peptic ulcer formation. Radiation therapy alone has little effect on the client's survival. However, it may be effective with pain relief. Currently, a combination of chemotherapy and radiation therapy is being used as it helps with long-term survival. It is important to monitor the patient's vital signs. Tachycardia could indicate a fever or pain. An elevated blood pressure may be due to pain or anxiety, and fever related to infection may be due to the blocked bile duct. The location and intensity and duration of the pain should be monitored. If the patient begins to have a distended abdomen, this could be the presence of ascites, which is common in the advanced stage. The presence of a tumor or the removal of the pancreas may cause an increased serum glucose level because the pancreas is no longer able to secrete insulin. Because of the impaired insulin secretion from the pancreas, it is important to assess the patient for levels of hyperglycemia or hypoglycemia. If the patient's skin becomes discolored, for example, a yellow tinge color, this could be because the biliary tract or the bile duct has become blocked by the tumors and is preventing the flow of bile from the gallbladder. Carefully monitor the patient's intake and output of fluids, as this is important to prevent dehydration. In the presence of ascites, fluid shift from the intravascular space may occur. Post-op assessment and monitoring should include vital signs, abdominal assessment, pain management, glucose monitoring, NG tube output, and surgical site assessment. The NG tube should never be manipulated. Nursing action should include maintaining hydration, maintaining NPO status until the GI function is returned. NG tube should be set at the low intermittent suction. And what this does, it decompresses the distended stomach and decreases GI motility. Insulin should be administered to manage glucose levels. The patient should be encouraged to cough and deep breathe to ensure and also ensure adequate nutritional intake. If the patient is losing weight, this may be due to a malabsorption of nutrients and the presence of a tumor. If the patient is having pruritus or itching, this could mean that bile salts is accumulating under the skin because the bile duct has been blocked. The patient may lose weight secondary to muscle mass, and this is called cachexia. And this may be because the patient has become anorexic and protein metabolism has been altered. Teach the patient what to expect after surgery, as this will help with prescribed interventions. The patient should also be educated about medication, in particular pain medications, which may cause constipation. Ensure that the patient is getting adequate nutrition, as this will help with weight gain and the healing process after surgery. They should be taught about the signs and symptoms of hypoglycemia and hyperglycemia, the symptoms that are associated with the disease, the progression of the disease, diagnosis, and the interventions associated with the disease should also be taught to the patient. It can be difficult dealing with a diagnosis of pancreatic cancer. Therefore, it is important that the patient is given information about support groups, networks, also the family, and ways in which they can cope with the situation.